Good day. My name is Melinda Mushonga, a clinical fellow at University of Toronto, currently at Sunnybrook Health Sciences. My most sincere apologies I could not join you in person due to factors beyond my control. I really look forward to enjoying the sun and at the same time share ideas on choosing wisely Africa. I have no pertinent conflict of interest issues to declare. Cancer incidence and mortality is rapidly growing worldwide, and this seems to be at par in Africa and other low-middle income countries. For example, incidence in Africa is 5.7%, yet mortality is at 7.1% compared to North America, whereby mortality is almost 50% lower than the incidence. In Africa, the cumulative risk of death from cancer in 2020 was high, and unfortunately, there are inadequate resources in low-middle income countries for optimum management of cancer. Sustainable infrastructure for the provision of cancer care in transitioning countries is therefore critical for an equitable global cancer control. This includes packages of resource-sensitive interventions such as appropriate utilization of radiotherapy. Radiotherapy is a fundamental component in cancer care. Fewer than 4% of the world's radiotherapy machines on the entire continent of Africa. Unfortunately, most patients in Africa present with advanced stage cancer and therefore require radiotherapy in the curative setting and in the palliative setting. How then do we ensure access to quality cancer care? Several factors come into play. One of them, choosing wisely the treatment strategy for each patient, evidence-based and appropriate for the clinical picture. These were established in 2012 to support the delivery of safe, cost-effective care. They remain particularly relevant in low-middle income countries. They promote discussion between clinicians and patients about care that is supported by evidence, not duplicative of other tests or procedures already received, free from harm, and truly necessary. The Choosing Wisely Africa recommendations were established in 2020 at the IOTEC regional meeting. These were built upon Choosing Wisely Canada, USA, and India through a modified Delphi process, and representatives from surgical, medical, radiation oncology, and the private and public sectors and patient advocacy groups participated in this. Ultimately, they identified 10 low-value common interventions in Africa's cancer practice which should be avoided, and 5 of these are most specific to radiation oncology, which we'll focus on in this presentation. This table is showing the 10 recommendations. Firstly, do not initiate cancer treatment without defining the extent of the cancer through clinical staging and discussing the intent of treatment with the patient. This allows an objective determination on intention to treat. To establish patients with stage 4 metastatic disease versus those who may need neoadjuvant treatment to improve outcomes. And for patients with stage 4 disease, it allows discussions on shorter palliative regimens compared to multifractionated regimens. Do not perform surgery to remove a breast lump without histologic confirmation of malignancy unless a needle biopsy cannot be performed. This avoids inadequate surgery compromising clinical outcomes. In addition, it reduces the risk of positive margins in patients who otherwise may have low-risk pathologic features, such that radiotherapy omission would have been an option to discuss in situations where re-excision could not be redone. Do not treat low-risk clinically localized prostate cancer without discussing active surveillance as part of the shared decision-making process. This avoids unnecessary radiation-induced toxicity when RT could be avoided in these settings. Do not initiate longer courses of radiation therapy where evidence supports the use of shorter courses of radiation. For example, use of a single fraction of palliative radiation for an uncomplicated painful bone metastasis, and use of shorter courses as part of breast conservation therapy in patients with early-stage invasive disease. There is well-established evidence for hypofractionation in breast cancer, which we will discuss more in subsequent slides. In addition, there's level 1 evidence for shorter fractionation in painful bone metastasis. Do not use surgery as the initial treatment without considering pre-surgical systemic therapy and or radiation for certain cancer types and stages where it is effective at improving local cancer control, quality of life, or survival. Evidence-based sequencing of radiotherapy in the neoadjuvant setting improves clinical outcomes. For example, in the colorectal setting, the Dutch trial and the Swedish rectal cancer trial, in esophageal cancer, the CROSS trial, in lung cancer, the intergroup 0160 for superior sulcus tumors, they all showed improved outcomes in patients who received neoadjuvant chemoradiation. How then do we implement choosing wisely in radiation oncology? Hypofractionation and the curative setting is one aspect. Omission of RT if clinically indicated. Radiotherapy as a neoadjuvant treatment modality. De-escalation or exclusion of low-risk treatment volumes. Use of shorter fractionation or split course treatment regimens in the palliative setting. What are the advantages? There's better compliance, therefore favorable outcomes when fractionations are less. Access to treatment improves as these reduce pressure on resources and more patients can be potentially treated. Reduced to no treatment-related acute toxicities. Financial relief to patients and health systems in cases where the billing system is based upon number of fractions and number of fields. Reduced hospital visits, which has become more relevant in the COVID pandemic, therefore reduced exposure and potential to COVID-19 infection. From a radiobiologic perspective, models have suggested that a larger daily dose given over a shorter time is more effective for malignancies with a low alpha beta ratio such as breast cancer and prostate cancer. What then is the evidence available for hypofractionation in practice for common clinical scenarios? Breast cancer. The START-A trial, START-B trial, Canadian trial, Beijing trial, and the United States trial in post-mastectomy patients. These all showed equivalence of moderate hypofractionation in comparison to conventional fractionation regarding oncologic outcomes post either breast conserving surgery or in the post-mastectomy setting. Most recently, ultra hypofractionation has been employed in the breast cancer setting following publication of the Fast Forward trial. After 5 years follow-up, 26 gray in 5 fractions over 1 week was shown to be non-inferior to the standard 40 gray in 15 fractions over 3 weeks for local tumor control and was noted to be safe in terms of normal tissue effects in early-stage breast cancer. Prostate cancer. A systematic review which looked at 10 studies with 8,278 patients compared hypofractionation to conventional fractionation in different clinical scenarios. Moderate hypofractionation up to a fraction size of 3.4 gray was noted to result in similar oncologic outcomes in terms of disease-specific, metastasis-free, and overall survival, and there appeared to be little to no increase in both acute and late toxicity. However, the considerations that one has to be cognizant of in the clinical setting. What was the risk stratification for each of those trials? What was the endpoint studied? What was the radiotherapy technique? Is it available in my setting? Was there any use of ADT before employing some of the fractionations to individual patients? Cervix cancer. There is currently no level 1 evidence in support of hypofractionation. However, some clinicians in Africa may be adopting it based on survey data in published trials. In South Africa, a study which comprised of 104 patients with stage 3B cervical cancer received external beam radiation, 40 gray in 16 daily fractions with APPA fields, plus a brachytherapy boost, 9 gray in 2 fractions. These patients did not have any concurrent chemotherapy, but the outcomes were relatively comparable to published literature, whereby there was a complete response in about 70% of patients and disease-free interval at 20 months was noted to be 59%. There are, encouragingly, however, ongoing trials that will provide hopefully more evidence in support of hypofractionation for patients with cervical cancer. Notably, the HEROIC trial. There's a feasibility trial, which is looking at 14-15 fractions, external beam radiation, and a high dose rate brachytherapy boost versus 45 grain 25 fractions and a high dose rate brachytherapy. All patients will receive weekly cisplatin. The Mexican trial, which has the same, designed the same, however, is looking at 37.5 grain 15 fractions in the experimental arm. In head and neck cancers, de-escalation of treatment has been widely studied. For example, this trial looked at 197 patients, and all patients had ipsilateral node dissection and contralateral node dissection in 144 patients, but all patients received only ipsilateral radiation therapy. Of the 197 patients, 45 patients suffered from local regional recurrence, however, only 12 in the contralateral neck. This then showed that regional failure of the contralateral neck was low after surgery, and ipsilateral neck irradiation in head and neck carcinomas without midline extension, supporting evidence that contralateral neck radiotherapy can safely be omitted in head and neck cancers. In palliative radiotherapy, a systematic review looked at single fraction versus multifractionated palliative radiotherapy. This looked at 16 randomized trials, which included 2,513 patients. In this trial, there were no significant differences found in response rates in patients who got a single fraction of radiotherapy versus those who got multifractionated radiotherapy. However, retreatment was 2.5-fold higher in the single fraction radiotherapy arm. Hypofractionation in the real-world setting. One of my mentors, Dr. Daniel Rodden, did a survey which looked at uptake of hypofractionated radiotherapy in the real-world setting. Findings noted that despite conventional and hypofractionated radiotherapy being equivalent in many disease sites, there was less hypofractionation in low and lower middle income countries and in the Asia Pacific. Lack of long-term data, inferior local control, and toxicity were cited as some of the barriers. In addition, there was significant global variation in the use of hypofractionation for curative indications. Encouragingly, hypofractionation was acceptable in the palliative setting for breast, prostate, cervical, and bone metastasis. What is the update 2 years after inception of the Choosing Wisely Africa recommendations? There was agreement with Choosing Wisely Africa recommendations among frontline clinicians in sub-Saharan Africa in overall, and the majority stated that they always or often follow Choosing Wisely Africa recommendations. The lowest adherence was reported for radiation oncology specific recommendations, which is quite worrisome, whereby using shorter courses of radiation when appropriate was only recorded by 67% of respondents, and discussing active surveillance with patients with low risk prostate cancer at 70%. Most participants reported that implementing Choosing Wisely Africa recommendations would be relatively straightforward. However, they did note that the most challenging recommendations to implement were, once again, shorter courses of radiation when appropriate at 55%, consideration of neoadjuvant therapy instead of upfront surgery in 51%, and multidisciplinary input for curable cancers at 50%, all more relevant in radiation oncology. What then are the proposed next steps with all this information? Educational interventions. Discussing evidence available or upcoming in educational forums with stronger focus on radiation oncology are needed. Policy implementations whereby we promote designing billing structures that are not based on traditional parameters, such as fractionation in number of fields. Considering including patient advocates to aid discussions between clinicians and patients on choosing wisely in our clinics, and promoting clinical trials in radiation oncology focusing on hypofractionation in Africa. I would like to acknowledge Maria and the eCancer team for this opportunity to discuss this important topic, and Dr. Fidel, who has been initiating and pushing the Choosing Wisely Africa, initiating conversations in our region, Dr. Anna Mary Nyakabau, Dr. Ntokozo Ndlovu, Dr. Daniel Rodden, my mentors, and the Sunnybrook team, Princess Margaret team, University of Toronto, and my family. Thank you.